Okay, this is NCHAM's infanthearing.org website that you're probably all familiar with. Let me just go back to the home page. So I'm going to show you how to access a wealth of resources that have been developed over the last 18 months. So if you go to our homepage at infanthearing.org and then go to the resources tab right here, and then over on the left-hand side, there's a telehealth header. Under that, teleintervention, and a teleintervention guide, and then tele-audiology guide. We're going to focus the vast majority of today's conversation on tele-audiology, although we recognize that there's a lot of other applications of telehealth with EHDI programs, and those resources are also available on our website. But if you go to the tele-audiology guide and click on that, this material comes from largely from a previously funded project that came through NCHAM with the Project CARES Act. That money has now been completed, and today's roundtable is actually funded by the Centers for Disease Control and Prevention. But we want you to be aware of these resources, and some of you on the phone, as I looked at names coming in, have actually contributed to some of these resources. And this is a living page. So we are continually updating material on this. And we certainly invite any of you who have additional material that you would like to share with others to be in touch with us. Or if you see things about this web page that you think would be better if it were organized in a different way, we would be happy to consider your suggestions. And working together, I think we can make a lot more progress than working alone. So let me start this by just playing a short 7-minute video. Jeff Hoffman, many of you know from Nebraska, who's now quasi-retired at least, was the one who managed this project for us. And Jeff explains a little bit about where this project came from and some of the resources that are available. Following Jeff's introduction, then Jessica will talk about some of the great work she's been doing to promote and to use tele-audiology in routine practice. And then after her presentation, we're going to shift gears and convert this to a discussion where all of you will have an opportunity to share with us what you're doing, what some of the obstacles you've encountered and surmounted are, what some of the obstacles you're still facing, some of the keys to your success, as well as any questions that you have. So let's start off by playing this short video.
Hello, and welcome to NCHAM's Tele-Audiology Technical Support Series. This series of videos was developed to provide basic information about several areas of pediatric tele-audiology for those audiologists who are interested in adding some type of remote services. I'm Jeff Hoffman, the manager for the Tele-Audiology Project at the National Center for Hearing Assessment and Management at Utah State University. You know, for the last year, COVID-19 has forced us to live differently and to practice audiology differently. And even though teleaudiology has been around to some degree for a couple of decades, COVID-19 has required that we adapt to providing many audiological services at a distance, both for our safety and the safety of those we serve. And as we move beyond the pandemic, teleaudiology will remain a viable option to providing efficient and effective services. This teleaudiology project was funded by the CARES Act. The funding went to the HRSA Maternal Child Health Bureau, and then on to the Association for Maternal and Child Health Programs, and then to NCHAM. And it's a short time frame, 10 months from June 2020 through April 2021. In that short time, our goal has been to assist at least 75 audiology sites to be able to begin using some type of teleaudiology services for young children. For this project, we're defining pediatric as children ages birth to 5 years of age. The project has been guided by a steering committee consisting of 8 audiologists with various experiences with teleaudiology. The members are Jessica Messersmith from the University of South Dakota, Hannah Ditmars from the University of Nebraska, Lincoln, Brant Culpepper, the team lead with the Georgia EHDI program. Linda Hazard, who's the program director for the Vermont EHDI program. Marcia Fort is the EHDI coordinator for North Carolina. Bill Campbell is a retired pediatric audiologist from Ontario, Canada. Julie Purdy is the audiology manager at Rady Children's Hospital in San Diego. And Shelby Atwill is the EHDI audiologist in Oregon. You know, in addition to providing a depth of expertise to the project, they've also been very involved in developing resources and strategies for this project. And many of them are presenters for this series of technical support sessions. The project has developed several resources that we hope will be helpful as you consider beginning to provide new teleaudiology services. Most of these resources are readily available in this section of the Teleaudiology Guide, and I'll briefly explain each one. The steering committee has developed a flow chart to provide that big picture of teleaudiology. As you contemplate providing teleaudiology, there are 4 questions that need to be answered. The first being, do I need to do it? Is it something that's needed in your community? What do I plan to do? Do I plan to do remote ABRs, conventional audiometry, hearing aid, cochlear implant work? What do you need to consider as you provide these services? What are the privacy and security issues you need to take a look at? Can you get your IT department on board? Do you have organizational approval to do it? And then after you get those questions answered, then what do you need? What's the hardware? What's the software? What are the personnel that you need for this effective teleaudiology programs? So these questions lead you to explore the various components in developing a teleaudiology program. We also have a planning tool that's an easy to fill in form that really permits you to take that 10,000-foot view of what you plan to do. Many of the questions are the same. What type of services are you going to provide? What are the needs? What equipment? What are your protocols? What are your state's regulations? And what's your reimbursement? How does that guide your practice? How are you going to measure the outcomes? What's your quality improvement system like? At the beginning of the project, we conducted a literature review on the various aspects of teleaudiology. In the introductory guide to the learning community, we've provided links to over 30 articles that seem best for starting out in teleaudiology. We've also included instructions on how to self-enroll in the actual teleaudiology learning community on infanthearing.org. In that learning community, that serves as a library for links to well over 100 articles that seem really good as a foundation for audiology, teleaudiology. And they include some really good training videos from the University of South Dakota in training the remote sites. And you're welcome to self-enroll and begin checking out those many resources. Also on the infanthearing.org site is the teleaudiology guide that you're in now. This guide provides an updated general overview of the various aspects of teleaudiology and lays the groundwork for providing teleaudiology services. We've also created a closed group on Facebook, NCHAM, teleaudiology. It's a good place to post upcoming events and links to articles that you found, as well as starting a discussion. As the steering committee discussed all the various aspects of teleaudiology and analyzed the results of several surveys, we settled on providing technical support in 5 areas for this series of technical support sessions: remote infant ABRs, remote cochlear implant mapping, remote hearing aid programming, remote site selection and training, and privacy and security. These recordings of the technical support sessions and the PDFs of the PowerPoint presentations are available in this section. Another project is with the Schneiding Foundation Academy for Hearing Healthcare at the University of Nebraska-Lincoln, and they've developed a remote hearing aid programming simulation. Participants worked through a hearing aid simulation experience by remotely programming a hearing aid, and also hearing aid verification by obtaining an RECD measurement and completing speech mapping. And we anticipate that this simulation will continue to be available at the University of Nebraska-Lincoln following this project. And although this tele-audiology project, which was funded by NCHAM, is rather short, we have assembled resources covering many of the components of tele-audiology. Components to help you gain a basic understanding of tele-audiology, explore many articles covering the last few years of development, and tools to plan for adding one or more new remote audiological services. We wish you the best in your journey to begin providing tele-audiology services for young children. Thank you.
And thank you, Jeff. So I'm going to stop sharing my screen now and turn the time over to Jessica. We hope that those resources on that website will provide you with some information which will answer questions you have as you go along. Some of those questions that come up today, as well as questions you have in the future. So Jessica.
Thank you, Karl. Hi, everyone. I am Jessica Messersmith. And as Karl said, I'm going to be talking for about 20 minutes today with you. I'm going to get my screen shared here so that we can have a conversation about what we have been doing with tele-audiology in the state. Hold on, I want to get it set up so you actually see my correct screen. It's always the challenges of having two monitors. For a moment, you're going to see my kids. And there we go.
They look like kids you should keep.
Yeah, I'm pretty fond of them.
Good.
So as Karl said, I'm Jessica Messersmith. I am a pediatric audiologist and cochlear implant audiologist in one aspect of what I do. I also have an administrative role at the University of South Dakota as the Associate Dean for Academics for the College of Arts and Sciences. And I also play a role within our athletics department here at USD as a faculty athletics rep. So I put on lots of hats as I go through my day. A bit of disclosure on me. I am a co-PI on the HRSA grant we hold in South Dakota that funds our EHDI improvement programming. I was a member of that task force that you just heard Jeff talk about in that recording. And I am also a board member of JCIH. So through the content that we discussed today, I'm not going to talk about any specific manufacturers. Rather, I want to talk with you about what our experience has been in South Dakota, what we have done, and some considerations for you to make as you are thinking about tele-audiology in your state, regardless of whether you're just beginning or have already implemented. So really the primary purpose of my brief presentation here is to make sure we all have some common definitions, some common framework for our question session that's going to follow this, so that we can all be sure that we at least are starting from the same point of understanding for framing that conversation. So telepractice has really had a long history of being shown to be a valid and effective measure or effective process, for providing health services. And teleaudiology specifically has been shown to be a valid and reliable method for infant diagnostic testing. And that is particularly in South Dakota, where we have utilized teleaudiology, is at that step of infant hearing assessment. And we utilize what's known as a hub and spoke site paradigm in South Dakota, meaning that the audiologist is housed at what we would consider a central location. And then there are several facilities around the state known as spoke sites, where a trained personnel, usually a nurse or a nurse assistant, is at that remote location. And we also house the equipment at that spoke site, at that remote location. So again, where we're doing infant ABRs, infant hearing assessments, that equipment would be your ABR, your tympanometry, your otoscopy, things like that. And I'll talk a bit more about that in a moment. But this is a paradigm that we follow. Is this audiologist here at USD is largely how we run these, with those spoke sites being located at those remote locations. When you are initially setting up for a tele-audiology program, Jeff alluded to this, but there are some specific considerations that you would want to keep in mind as you're identifying those potential spoke sites in your jurisdiction or in your state. And they really need to progress from a more global consideration to a more specific consideration. You really do want to start initially with a determination of the needs of your state. I'm going to go through examples of what we in South Dakota identified as our needs, but you really need to step back and say, within my jurisdiction, what are the specific needs, the specific gaps that we are trying to fill? Is it a high loss to follow up for Eddie? Is it access to pediatric audiologists for hearing aid fittings, right? Like, what is that specific need that we want to fill? Once you identify those needs, you need to identify your priority for trying to address them. You're not going to be able to address all of those needs at the same time. Chances are, if you have a need for an infant hearing assessment due to high loss to follow up, you probably also have a need for remote hearing aid fitting for after diagnosis, if that's the option families choose to pursue. So you need to prioritize how you're going to implement and address these needs in a manner that's in line with the resources within your state, both human power as well as financial resources. That prioritization of needs is going to really drive your determination of what that geographic location within your state needs to be for these remote sites. You want to place your remote sites in the places that are going to have the greatest good, those places that are really going to be able to offset and address that need that you identified in the previous two steps. Then once you identify the specific geographic location, you want to hone in even more specifically and identify the specific site, the specific facility, and even the specific room within that facility and the specific persons within that facility that you need to engage. In South Dakota, when we considered our unique needs, we had 3 needs that really came to the surface for us. One is rurality. We are a very geographically isolated state. South Dakota is a frontier state in 34 of our 66 counties. And to be a frontier state, that means that you have to have 6 or fewer persons per square mile. So we are very, very rural. Further, our second really big challenge in South Dakota is we have a low average household income. That's what's demonstrated on the figure here. And I have South Dakota outlined in black for you there on the image so you can see where we are as a state. And the shading on this graph, or on this image, excuse me, represents the median household income. The darker the red, that is the lower the average household income. As you move towards blue, that is higher household income. As you can see, South Dakota is predominantly red and orange. South Dakota actually contains 3 of the top 5 counties with the highest rate of population living in poverty in the United States. And in fact, the second poorest county in the United States, the Ziebach County, is within the borders of South Dakota. So we have this combination of the state being very sparsely populated across a large geographic area, as well as low income levels that compound by a shortage of healthcare providers. I'll show on the next slide our locations of pediatric audiologists in the state. We have very low access to healthcare within our state. Every county within South Dakota, it has been determined in full or in part to be a health professional shortage area as defined by HRSA. So we really do have a lot of barriers that we have worked to overcome through our tele-audiology program. Within our state, I have on the image here indication for you of where our pediatric audiologists are housed. Those are the red dots that you see on the map. as well as where our remote sites, so spoke sites for our teleaudiology program are located. Those are those yellow spots. In South Dakota, our teleaudiology sites, our spoke sites that we identified those based upon the counties that have the highest loss to follow-up in our state, with a second primary factor of being that combination of the rurality of the area and the household income. In South Dakota, we have particular counties that have very high loss to follow-up rates, and those teleaudiology sites that we identified and have in place really got us close to those counties where we could try to specifically target populations living in that general geographic area to try to improve those loss to follow-up rates. So those are our sites. Then we had to set up, right? And so again, I said we use this hub and spoke site paradigm. So the hub, that's where the audiologist is housed. The spoke site, that's where the equipment is housed, that trained personnel. And then we communicate with one another through a remote connection. We use a video chatting software to be able to see each other. The audiologist needs to be able to see the family as well as that trained personnel, and that family and that trained personnel need to be able to see and communicate with that audiologist. We also have remote computer access. So the audiologist here at the hub site, I remote in and connect to that computer, that equipment that's located at the spoke site, and I control that equipment remotely to perform this testing. As I've already stated as well, we specifically have focused on remote infant hearing assessment. So the equipment that we have housed at those spoke site locations is that equipment that would be needed for that infant assessment. So a video otoscope, our frequency specific ABR equipment with air conduction and bone conduction transducers, OAE equipment, tympanometry, that computer, again, that allows for the remote connection, as well as having that computer on both ends that has the webcam accessibility so that we can have that video ability between the two places. When you identify your location and then obtain that equipment, which we all know can be quite expensive to obtain that equipment, that can take a while to accomplish. And I encourage everyone to be patient with themselves as they're working through that initial step. I saw Shelby on the call today, and Shelby is our grant coordinator for us, and she can attest to this as well. It took us a good 2 years of planning to be able to identify our remote sites, get the equipment obtained, and get set up to actually do the work that we've been doing. So be patient with yourselves as you're setting up. It's going to take some time to happen. When you get to the point where you have that remote site set up, you have your equipment, you aren't done with your work yet. You have to then step into a training role to ensure that that support personnel at the spoke site location is prepared to do the tasks that the audiologist is going to need them to do. In South Dakota, we did so through an on-site training. So our spoke sites, when we set them up, we go there to provide an on-site training with the equipment. We also created on-demand video trainings, and I'll be providing you those links here in a moment. Our hospital systems within the state uploaded those videos to their online or on-demand training systems as well, so that if there's a change or if that support personnel needs a refresh on how to do something, they're able to pull up that quick video to refresh themselves on how to do a particular step of this testing. We also created quick reference guides, a printed out laminated sheet of paper that, for example, shows them where electrodes go, shows them how to connect cables onto the computer, onto the hardware. We then also found extremely valuable to have a local champion at each of those spoke sites. And that's something I hope will come up in the question and answer period later. I don't want to spend a lot of time on it now, but we have found that our sites were most successful when we had someone at that spoke site location who was really championing this, who was talking with the referring providers, who was advocating for the importance of teleaudiology and was engaging that local community in connecting families with our services. That has been a primary win for us and something that we have identified as one of the true keys for success with teleaudiology. Here's those examples of those videos. I'm not going to show them to you, but I did provide the links here. And perhaps after this, maybe we can send this PowerPoint out to attendees so that they can have these links. When we developed these videos, we acknowledged that we had grant funding to do so, but not every clinic has that capacity to create training videos. So we tried to make them more generic and not specific to our clinic so that any other clinic in the US would be able to utilize these training videos. So these are located on YouTube. You can use the links. We just ask that you cite us when you utilize them, but feel free to use them. You do not need to recreate the wheel when setting up your remote sites. Those materials are there for people to be able to use. And I also have an example of one of those quick reference guides, those laminated pieces of paper that we have at the testing station at those spoke sites for that trained personnel to be able to pick up and reference at the time. We've really found those quick reference guides to be useful. Being in a rural state, we don't have as large of a volume of babies being seen as some of your more populated states may have. So this trained provider at that end, they may only be doing this testing for us once or twice a month, right? And we all know those things that we only do sporadically where you're not as effective and efficient in. So having these quick reference guides at the ready for that person really helps them to be able to place electrodes in the correct place, to be able to connect wherever they need to be. So some other lessons learned in South Dakota that I share that have helped us to really be successful is being very clear on that communication path and plan between the hub site and the spoke site. Who do families contact to schedule? If they contact the other site, what's the mechanism for getting them connected with that scheduling desk? Setting up specific scheduling appointments. For us, having a fixed appointment day and time has been something that has really allowed us to be successful, and I'll talk about that more on the next slide. We also encourage people to consider through what does that consenting process look like, and related, who owns that patient and their records in their database. In South Dakota, we're doing this across healthcare facilities. So I am, as an audiologist, I'm actually independent of our primary health systems in South Dakota. We have three primary health systems. And so through this, I've gained credentials and received privileges at these hospitals, but we still have to be very clear about who owns those medical records and having the releases signed so that we can be sure that we are legally sharing them across locations. We then also have to be very clear about what happens after a diagnosis occurs and who is taking responsibility for this family and supporting this family to help them identify the resources when they are at a distance from the audiologist. So in South Dakota, as I said, we found what worked for us was having a fixed appointment time per spoke site each month. So each spoke site knows from month to month that they have, for example, Tuesday mornings at 10 a.m. That's their time that they can schedule. Or a second spoke site, they may be Thursday afternoons at 2 p.m. But we've established with each of those spoke sites what specifically works for them and for us. And it is just a standing held appointment so that they know and we know when a family needs to be scheduled, that's the time that we can be in. We then really have to be effective in the frequency of that communication as well, being sure that we're touching base as that appointment grows close to assume that for us, the spoke site has confirmed the appointment with the patient and that we at the hub site have confirmed all of that with the spoke site. For us in South Dakota, when we considered what happened after the diagnosis, We are very fortunate in South Dakota for how our School for the Deaf works. In South Dakota, the School for the Deaf operates as an outreach service. So they have trained outreach providers, if you will, across our rural state, where we as the diagnostic facility can connect that family with that outreach consultant who's local to them, who is a trained deaf educator, who can help to support that family get connected with Hands and Voices, get connected with Birth to 3, get connected with those various services across the state. And they can really be an ally for that family in helping them to navigate this rural state that we live in, to move that family forward in whatever decision processes they are making. We also are very clear on the referrals that happen after a diagnosis to ensure that we're getting that family connected to Birth to 3 services, primary care providers, as well as sending those results back to the South Dakota EHDI program. In South Dakota, we've been pretty successful with this, I would say. Our state population, as I've said, is very rural. So some of you may look at these numbers and think those are pretty low. But in South Dakota, we're actually doing quite well. In South Dakota, we estimate that we probably have approximately 50 babies per year born with some degree of hearing loss. A good portion of those are seen in our primary population centers in the state. So in these more rural areas, we are going to have fewer babies who are born with that hearing loss present. You can also see on this image that during that period of COVID, the number of babies and families we were seeing really dropped off. For a period of that summer, from March of 2020 through June of 2020, many of our spoke site centers were closed for outpatient, so we were not able to see families during that 3-month period. And then after that, it's really taken us some time to ramp back up to having a good follow through with families. And as you can see, since the summer, we have really started to increase. And actually, when you look at our schedule here in the upcoming weeks, Hannah is on here. She's my GA. She would know the exact number. I believe in the next 2 to 3 weeks, we have an additional 5 or 6 babies scheduled. So we are really ramping back up here and really probably soon going to exceed where we were pre-2020. Where we are now, we still have some challenges. We still, in those counties, still have high loss to follow-up rates. And at our sites, our spoke sites, we are still having pretty high loss. We're still having a hard time consistently getting families to come to those appointments. We probably have in some of those locations about a 60 is too high, about a 40% no-show rate. So we're really trying to target some of those pieces of our process to try to ensure that we're using everyone's time effectively and we're really reaching families where they are. We are also working to improve the referral process at those spoke sites. Some of our facilities have a specific pediatrician who these families largely see. Most of them do not. Most of them, these babies, these families are seen by primary care physicians, family practice physicians, spread out in rural community clinics. And we're really trying to fine tune our process so that those physicians and those nurse practitioners who more infrequently see these families can know this referral process and be able to connect those families with us. So that is a pretty quick and dirty review of what we're doing in South Dakota. I'm going to stop my screen share now so that I can see some comments. And feel free to pop your comment in the chat. If you would like, raise your hand and we can have you unmute your microphone if you would like to ask your question to the group. Really, this can be question and answer. It can be discussion amongst all of you. I saw in the chat that many of you have a lot of experience with tele-audiology, so you all may be able to be great resources for each other with some of these questions as well. Oh, Karl, I think you're muted if you're talking to us.
I am muted. Thanks, Jessica. So that was a great overview, and some of the things that really struck me was the importance of being patient, but still be persistent. It's pretty clear that teleaudiology just doesn't happen because someone has an idea, that there's a lot of work that goes into it, a lot of details, and that need for a local champion to really keep it moving along, I think is something that we don't often think about, that it's the people who are in the trenches that are there advocating for it that make the difference between success and failure.
It
So
really is, right? Like with that, if I can elaborate that on a moment, what we, like maybe one way to describe that is, it's kind of that out of sight, out of mind, right? We all experience that in life. If you're not engaged with something and seeing it in your everyday life, oftentimes you do forget about it, or it falls to the back of your mind. With these remote sites, I'm not there, or my other audiologists aren't there, but that local champion is, and they can be that visible person who really keeps this at the forefront of those providers' minds, of the families' minds, that this is something that's important and this is something that's available.